People who caught their surgeon operating drunk. What happened? The smell hit me before anything else did. I was lying on the gurney outside operating room 3, already pre-medicated, the edges of the world going soft and warm, the way they do when the anesthesiologist has done his job, and the double doors swung open, and Dr. Harlan Boyce leaned through them, and the smell came with him. Sharp, sweet, unmistakable. I had smelled that exact combination. Whiskey and mint. Whiskey losing? On my father every Friday night for the first 16 years of my life, and my body knew what it was before my brain finished processing it. My brain, softened by midazolam and fentanyl, tried to file it away as something else. Aftershave, mouthwash, the antiseptic fog of a hospital morning. But my body knew. My hands gripped the side rails of the gurney, and my pulse jumped, and a voice somewhere behind the medication fog said, "This is wrong." Harlan Boyce was scheduled to operate on my spine that morning. He was going to cut into the space between my L4 and L5 vertebrae and repair a disc that had been compressing my sciatic nerve for 2 years, destroying my ability to walk more than 3 blocks without my left leg going from pain to numbness to nothing. He was one of the most decorated spinal surgeons in the state. He had a wall of credentials I had personally read in his office 2 months earlier while waiting for our consultation. He smelled like a man who had started drinking before sunrise. And I was already on the gurney, already medicated, already inside the machine. I had been living with the disc injury for 2 years and 8 months when I finally agreed to the surgery. That timeline matters because it means I had tried everything else first. The physical therapy, the epidural steroid injections, the chiropractors, the pain management specialist, who put me on a course of gabapentin that left me fog-brained and still hurting, the second opinion that confirmed the first opinion, the third opinion that confirmed the second. I was 38 years old, a structural engineer for a mid-sized firm, a person whose entire professional identity was built on physical site visits and the ability to walk job sites for 6 to 8 hours at a stretch. And the disc was taking that from me 1 month at a time. My name is Garrett Osey. I am methodical by training and by nature. I do not make large decisions quickly. I researched Harlan Boyce for 3 weeks before booking the consultation. I read his published papers, his hospital affiliations, his malpractice history, clean as far as public records could tell me, and the testimonials of former patients on every platform I could find. He had a 17-year career at Meridian Regional Medical Center, a fellowship at a teaching hospital in Boston, and a patient satisfaction rating that sat consistently above 92%. He was 61 years old. He had the steady, authoritative manner of a man who had opened thousands of bodies and closed them again and understood that the people on his table needed to believe completely that they were in capable hands. I believed it. That was my mistake. Though I am not sure believing it was something I could have avoided without the evidence I did not yet have. The first sign I missed came 4 weeks before the surgery date at my preoperative appointment. I arrived at 9:15 for a 9:30 slot and was shown to an exam room where I waited until 10:40, which is not unusual in surgical practices. And when Boyce came in, he was moving with a slight, controlled deliberateness that I clocked as fatigue. I told myself he was tired. He was 61. He had probably been in a surgery since 6 in the morning. He reviewed my imaging, confirmed the surgical plan, answered my questions, all correctly, all coherently, and I walked out satisfied. What I noticed but did not register was that he did not sit down during the appointment. He stood the entire time, one hand on the counter, eyeing with the specific posture of a man who needs something to hold on to. I had spent enough time on construction sites to recognize that posture. I did not connect it. The second sign came from his nurse, a woman named Dolores Vane, who had worked with Boyce for 9 years and who, when I called to ask a follow-up question about post-operative restrictions the week before the surgery, said something that seemed like professional courtesy at the time, but that I would think about many times afterward. She said, "Dr. Boyce is very thorough. He'll take good care of you. Just make sure your support person arrives early and is prepared for the possibility of the timeline shifting." I said, of course. I hung up. I did not ask why timelines shifted, what caused them, whose timelines had shifted before mine. I was 38 and in pain, and I wanted to be fixed, and Dolores Vane's 9 years of careful diplomatic language had been constructed precisely for people like me. My brother Kwame was my support person, which meant he was sitting in a waiting room on the 3rd floor of Meridian Regional at 6:45 on a Monday morning while I was being prepped for a procedure scheduled to begin at 7:30. The prep went normally. The IV went in on the first try. The anesthesiologist, a calm, efficient man named Dr. Tomas Brewer, introduced himself with 18 years of anesthetic experience and walked me through the plan with the measured precision of someone who takes seriously the fact that he will be controlling whether you breathe. He initialed my surgical site. He reviewed my allergies. He said everything is going to go smoothly and I had no reason to disbelieve him. At 7:12, a transport orderly wheeled me toward OR3, and at 7:14, the double doors swung open and Harlan Boyce stepped through them, and the smell arrived with him like a third person entering the room. My medicated brain tried to dismiss it. My unmedicated instincts would not cooperate. I looked at his eyes. They were slightly glossy, not dramatically, not the rolling glassiness of someone profoundly intoxicated, but the specific dull sheen that sits behind a person's eyes when they have been drinking and have not slept it off. He said, "Good morning, Garrett," and his voice was steady, his diction clean. He was functional. That was the terrifying part. He was not falling down drunk. He was operating on your spine drunk, which is a different category entirely. And the difference was not visible unless you had grown up learning to see it. I said his name. He looked at me. I said, "I need to ask you something before we begin." He said, of course, with the patient indulgence of a man accustomed to pre-operative anxiety. I said, "Have you been drinking this morning?" The room changed, not dramatically. No one gasped, no one dropped anything. The monitors kept beeping at the same rhythm. But something in the quality of the air shifted, the way air shifts in a room where something real has just been said out loud. Boyce looked at me for exactly 3 seconds. He said, "That's not a question I expected." And then he turned to the scrub nurse and said something I could not hear. And the scrub nurse went very still, and Dr. Brewer, but who was behind me and whose face I could not see, said nothing at all for a moment that lasted too long. I said, "I am asking because I can smell alcohol." I said it clearly, with the medicated effort of someone working against sedation to be precise. And Boyce said, "You're anxious and the medication is affecting your perception," which was technically a sentence that covered all of its bases. Not quite a denial, not quite a dismissal, a formulation that left him room to retreat in any direction. That formulation, I would later understand, was not improvised. People who are accustomed to this situation develop language for it. I said, "I want the surgery postponed." Boyce said that was not his recommendation. I said I was aware of that. I said it was mine. Dr. Brewer said, quietly and with no particular inflection, that the patient has the right to postpone. Boyce said he understood. He left the room. I was wheeled back to pre-op holding, and I lay there with the midazolam wearing thin and my heart doing something complicated, and I thought, what do I do now? What I did was call Kwame. My phone had been in a plastic bag in a pre-op locker, but the nurse retrieved it when I asked, and I called my brother and told him to come to the pre-op bay immediately and not to talk to anyone on the way. He arrived in 4 minutes, which meant he had been moving fast, which meant my voice on the phone had communicated something my words had not explicitly said. I told him what had happened. He sat in the chair beside the gurney and listened without interrupting, which is the thing about Kwame. He is 42, a former Marine, and he processes information before he reacts to it, which is the single most useful quality a person can have in a crisis. When I finished, he asked me 2 questions. He asked whether I was certain about the smell. I said yes. He asked whether I had said so clearly, on record, to a medical professional in the room. I said yes, Dr. Brewer had been present. Kwame said, "Then the next thing is documentation." He took out his phone and opened his notes app and wrote down the time, 7:19 a.m., and a summary of what I had told him, and he asked me to confirm every detail before he locked the note. Then he went to find the charge nurse for the surgical floor, a woman named Rosario Fuentes, who had been working surgical at Meridian for 14 years and who, when Kwame explained that his brother had just requested a surgical postponement due to concerns about the operating surgeon's sobriety, went very quiet in the way of a person who is not surprised by the information, but is recalculating what it means for her professionally. She said she would notify the surgical director. She said this with the careful neutrality of someone who has been trained to say exactly this and nothing more. The surgical director was a man named Dr. Philip Nakamura, who arrived in the pre-op bay at 8:03 in a suit rather than scrubs, which told me he had come from an office rather than a procedure. He introduced himself with the title and the name, and then said he understood I had some concerns about the morning's surgical plan. I said yes, I said specifically that I had concerns about Dr. Boyce's condition. Nakamura said he had spoken with Dr. Boyce and that Boyce had indicated I was anxious about the procedure, which is a very old institutional playbook. Take the patient's accurate observation and reclassify it as a symptom of the patient's emotional state. I looked at Nakamura and I said, I have been sober my entire adult life because my father was an alcoholic. I know what alcohol smells like on a person who is trying to conceal it. I know the difference between that smell and mouthwash, between sedation-induced confusion and an accurate sensory observation. I am telling you that your surgeon smelled of alcohol at 7:14 this morning. Nakamura was quiet for a moment. Then he said he took all patient concerns seriously. He said the hospital had protocols. He said there would be a review. He said all of these things in the particular language of institutional self-protection. And I listened to all of it, and I said, I want that review documented, and I want to know the outcome. And if I discover that this concern was dismissed without genuine investigation, I will be pursuing every available avenue. Nakamura said he understood. He left. I looked at Kwame. Kwame said, We're getting a lawyer today. I said, I know. The lawyer was a woman named Adrienne Solberg, who had been practicing medical malpractice and patient rights law for 19 years, and whose firm had handled 11 cases involving impaired surgical personnel, a specific subspecialty she had developed after a personal experience she mentioned once and did not elaborate on. Kwame found her through a referral from a colleague and had her on the phone within 2 hours of leaving the hospital. We met in her office that afternoon, still in the clothes we had worn to the hospital that morning, and I went through everything again from the beginning. She asked questions the way a surgeon operates, precisely without wasted motion, knowing exactly what she was looking for. She asked whether I had been alone with Boyce at any point when I noticed the smell. I said no, the scrub nurse and Dr. Brewer had been present. She said Brewer's presence was significant. She asked whether I had explicitly stated my concern out loud in that room. I said yes. She asked whether Rosario Fuentes had been the charge nurse I spoke to. I said yes. She said Fuentes had 17 years at Meridian and a reputation for accurate documentation. She said, the hospital is going to conduct an internal review, and that review is going to be designed to protect the hospital. What we need to do in parallel is establish an independent record of your concern before their narrative gets settled. She filed a formal patient complaint with the state medical board that evening, under case number 24-MB-3819. She also sent a litigation hold notice to Meridian Regional, demanding preservation of all records, communications, scheduling documents, and personnel files related to Dr. Harlan Boyce from the previous 18 months. The medical board assigned an investigator named Dr. Constance Abubakar, a physician with 20 years of clinical experience and 8 years in regulatory oversight, who contacted me within a week to schedule an interview. I met with her in person with Adriana present, and I told her everything, including the specific quality of the smell, the glossy quality of Boyce's eyes, the 3-second pause before his response to my question, and the language he used, that my anxiety and the medication were affecting my perception. Dr. Abubakar wrote everything down in a yellow legal pad with a mechanical pencil. And when I finished, she said she had a few additional questions. She asked whether this was the first time I had met Dr. Boyce in a clinical setting. I said no, I had had the preoperative appointment 4 weeks prior. She asked whether I had observed anything concerning at that appointment. I described his posture, the deliberateness of his stillness, the hand on the counter. She wrote it down without reaction. She asked whether I had any history of anxiety disorders or substance use that might be relevant to my perceptual reliability. I said no, and I told her why. The sobriety, my father. The 14 years of understanding that smell in all its variations. She nodded. Then she asked a question I had not anticipated. She asked whether I knew if any other patients or staff members had raised concerns about Dr. Boyce. I said I did not know. Her face did not change, but she wrote something additional in her notepad and underlined it, and I saw her underline it, and I understood that the question had not been idle. What Dr. Abubakar had, and what I did not know about yet, was a pattern. Adriana discovered this 4 weeks into the process when the medical board's investigation, running parallel to but separate from Meridian Regional's internal review, began producing information that the hospital's self-protective process had been structured to contain. A scrub nurse named Felicia Drummond, who had worked in Meridian's OR suite for 6 years, had filed an anonymous concern through the hospital's employee safety reporting system 11 months earlier, citing erratic behavior and an unusual smell on Dr. Boyce during a procedure. The concern had been received, documented, and assigned to a supervisor who had spoken to Boyce privately and noted no further concerns. The anonymous report had not been escalated to the medical board. It had not been escalated to anyone outside the hospital. It had been filed in a system that Meridian's own risk management team had access to, and that Meridian's own legal counsel had reviewed and determined did not rise to the level of reportable concern. Felicia Drummond, when the medical board investigator spoke to her directly 8 months after her anonymous report, confirmed she had filed it. She said she had been afraid to put her name on it because she had worked with Boyce for years and did not want to be the person who ended a decorated surgeon's career on something she could not prove. She had told herself it might have been a one-time thing. She had watched him carefully for weeks afterward and had not noticed anything definitive. She had concluded with the logic of someone who needed to keep coming to work that she had probably been wrong. She had not been wrong. Yet the crisis compressed into a 72-hour window in the third week of the investigation. Adrienne called me at 6:48 in the evening on a Wednesday and said the medical board had found additional information she needed to discuss with me immediately. I drove to her office. She had 2 documents on her desk. The first was a toxicology report from an independent blood draw that the medical board had ordered as part of their investigation, conducted earlier that week, which showed a blood alcohol concentration in Boyce that, while below the legal limit for driving, was above 0 at 9 in the morning on a scheduled surgical day in a man who had maintained to the board that he consumed alcohol only socially and never before clinical hours. The second document was a complaint filed by the family of a patient named Reginald Thorpe, an 64, who had undergone spinal surgery with Boyce 14 months earlier and had experienced a nerve damage complication that left him with permanent partial loss of sensation in his left hand. Thorpe's family had been told by the hospital that the complication was a known surgical risk, which was true. It is. What the hospital had not told them was that Felicia Drummond's anonymous concern had been filed 6 weeks before Thorpe's surgery. Adrienne put both documents on her desk side by side and looked at me and said, "This is not a single incident case. This is a pattern that the hospital knew about and did not address." My hands were flat on her conference table. I pressed them harder against the surface. I said, "What does this mean for Reginald Thorpe?" She said it meant his family needed a lawyer, and that she was going to make a call as soon as I left her office. The institutional failure became undeniable from multiple directions simultaneously. The state medical board's investigative report, completed in its preliminary form 6 weeks after my complaint, found sufficient evidence to suspend Dr. Harlan Boyce's surgical privileges pending a formal hearing. The report cited my complaint, Felicia Drummond's prior anonymous report, the toxicology finding, and a review of Boyce's surgical outcomes in the preceding 18 months that showed a statistically elevated rate of minor complications compared to his prior years. Not dramatic enough to have triggered automatic review, but visible in aggregate to someone who was specifically looking. Dr. Nakamura, Meridian Regional's surgical director, was summoned before the board's hearing panel and asked to explain the handling of Drummond's anonymous report. His answers were not sufficient. The board found that the hospital had failed to fulfill its mandatory reporting obligations under state medical practice law when it received the anonymous concern and did not escalate it externally. Meridian Regional's board of directors placed Nakamura on administrative leave 2 days after the hearing panel's preliminary findings became public, which they did when a health reporter at the regional paper named Octavia Renard published a piece that Adrienne had been, very carefully and legally, making sure Renard had the right background to write. The piece ran on a Friday. By Sunday, 3 other former patients had contacted Adrienne's office. Boyce's formal hearing before the medical board took place 8 weeks after the preliminary suspension. I testified for 47 minutes. I described the smell, the eyes, the 3-second pause, the language of his response. I described my father. I described the 14 years of sobriety and the specific, trained attention to the smell of alcohol that sobriety builds in a person. Felicia Drummond testified in person, this time with her name on the record, in a clear and steady voice that she said she'd been practicing in her bathroom mirror for 3 weeks. Dr. Brewer, the anesthesiologist, submitted a written declaration confirming that he had been present when I stated my concern, that I had stated it clearly and specifically, and that, in his professional opinion, the patient's concern had been reasonable and warranted further investigation. He had not volunteered this information before being formally requested by the board. When Adriani asked him why, he said he had hoped the internal process would handle it. He said that with the specific regret of a person who knows what hope-based reasoning costs. Boyce did not testify at the hearing. His attorney submitted a statement acknowledging a substance use disorder and citing a treatment program he had entered voluntarily 3 weeks after his suspension. The statement expressed remorse. It described a years-long struggle. It asked the board to weigh his career of service against this documented failure. The board weighed it. His surgical license was revoked. Permanently. He would never operate again. Reginald Thorpe's case settled out of court 14 months later for an amount his family's attorney described to me in a brief phone call Adrian arranged between us as significant. Significant enough to cover his ongoing medical care. Significant enough to mean that what happened to his hand, the numbness that would never fully resolve, the grip strength that had dropped by 30% according to his neurologist, would not also cost his family their financial stability on top of everything else. That was not justice. It was the version of it that the legal system produces in cases like his, which is partial and monetary, and is the most the system knows how to do. Reginald Thorpe called me himself once, on a Thursday evening in October. He was 65 by then. He said he wanted to say thank you, which made me feel strange because I had not done anything except refuse to get off a gurney when my body told me something was wrong. I said I was sorry it had taken my complaint to surface what his family's complaint had not. He said he understood. He said the hospital had been very convincing. He said he had believed them because they were the hospital, and he was just a patient. And that is the fundamental arithmetic of institutional trust. The institution has credentials and language and the weight of its reputation, and the patient has what they felt and what they smelled and what they knew in their body before the medication softened the edges. He said he was glad I had held on to mine. I told him I thought about him a lot. He said he thought about me too. We hung up, and I sat with the phone in my hand for a while. I had the surgery 5 months after the morning in OR3, performed by a spinal surgeon named Dr. Yewande Olufemi, who had been practicing for 12 years and who came recommended by 3 separate physicians I trusted, and who on the morning of the procedure arrived in the operating room, smelling of nothing at all except the particular clean, antiseptic air of a room prepared for someone to be made well. She was thorough and calm, and explained every step to Dr. Brewer, yes, the same Brewer, who had specifically requested to serve as anesthesiologist on my procedure, which I understood as the closest thing he could offer to an apology without saying the word. And the surgery took 3 hours and 14 minutes and went without complication. I woke up in recovery with my left leg present in a way it had not been present for 2 years and 8 months. The sciatic nerve, decompressed, was sending signals that were clean and clear and mine again. I lay there feeling them and thought about the gurney and the smell, and the 3-second pause and the medicated effort it had taken to say the words clearly enough to matter. My father had spent 16 years teaching me what that smell meant, which was not what he intended to teach me, but it was what I learned. I am 39 now. I walk job sites for 8 hours at a stretch without my left leg going numb. Harlan Boyce's license number appears in the state medical board's public revocation records, which are searchable by anyone who wants to look. Felicia Drummond still works in that OR suite. And the last time I spoke with Adrienne, she mentioned that Drummond had been formally recognized by the Nursing Association for Patient Advocacy. It is not the story I wanted to live. It is the story I have. And if it means one other person on one other gurney holds on to what their body knows long enough to say it out loud, then the 72 hours in the hearing and the phone call with Reginald Thorpe were exactly worth what they cost.